welcome everyone. My name is Kelly Harding, and I'm the host of today's webinar. I'm the Director of Research Administration and a Research Associate with CanFASD. My background is in human development and interdisciplinary health, particularly in rural and northern communities, but I've worked in the field of FASD since 2010, and I'm involved in a diverse research project spectrum in a lot of different areas, mostly in FASD prevention and women's health, mental health, housing, and human rights. But more importantly, I get to join you as the host today in my capacity as the organizer of the CanFASD Trainee Program. So I would first like to begin our meeting today with a land acknowledgement. An important step in reconciliation is the acknowledgement of traditional treaty lands and recognition for the people of the territory. The Canada FASD Research Network recognizes the historical significance and contributions of Indigenous peoples and their cultures, and understands the important role that the Indigenous community plays today and in the future. We acknowledge that we live, work, and meet on traditional territories across Canada of many of the First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I wish to acknowledge that the land on which I personally gather, work, and play is in Robinson-Huron Treaty Territory and the traditional lands of the Atikameksheng Anishinaabe and the Wanapitei First Nation. So today's webinar is a special one as it showcases the work of this year's CanFASD trainees. So the trainee program is designed for students, early career researchers, and professionals in Canada who are working in the field of FASD. Beginning in January of this year, 10 trainees were invited to take part in the program. Nominated by our CanFASD research leads and associates and our community partners connected to CanFASD, the trainees represent a pan-Canadian group of interested students, researchers, and service providers from a wide range of disciplines and levels of training. The goals of this program are to build research capacity in the field of FASD, to foster mentorship, networking, and collaboration among trainees and leading Canadian researchers, and to encourage the next generation of up-and-coming FASD researchers. As part of this program, our trainees have the opportunity to profile their work to the CanFASD network through blog posts, newsletters, and public presentations, including today's webinar. Given that the trainees are a diverse group, you're all going to hear about a variety of projects using different approaches and methodologies, and also in various stages of completion. So with that, today you will hear from 5 of our trainees on a wide range of topics, and I have the honor of introducing our first presenter today, Jasmine Kowalewski. Jasmine is a master's student in school and clinical child psychology at the University of Alberta. Her research focuses on a range of different topics, from neuropsychology to systemic racism. Jasmine's presentation today explores issues surrounding FASD and Indigenous peoples. So with that, Jasmine, I will pass it over to you.
Awesome. Thanks so much, Kelly, for the introduction. So I'll just get right into it. So again, my name is Jasmine, and I'm a master's student currently at the University of Alberta. And today I'm going to be presenting on fetal alcohol spectrum disorder and Indigenous people, a call for cultural relevant solution. And this presentation doesn't necessarily match up with a specific research question, but it's more of kind of just like an exploratory talk to kind of introduce people, to the topic. So to start off, I want to give you a brief overview of what the presentation is going to be about. So first off, I'm going to introduce FASD with a definition, mention the prevalence of FASD among Indigenous people. Then I will talk a little bit about the historical and cultural context involving colonization and Indigenous knowledge systems. Then I will touch on a few of the diagnostic challenges that Indigenous people experience. And then fourth, I'll mention the importance of cultural safety, which leads into how to be a cultural safe clinician. So it's important to note that FASD does not have a universal definition. And this one I gather specifically from the CanFASD Research Network on the website, because I thought I did a really good job of mentioning all the different aspects of the disorder. So FASD is a diagnostic term that is used to describe the impacts of the brain and the body on individuals who are prenatally exposed to alcohol. So this is going to be a lifelong disability, and individuals with FASD might experience some degree of challenges in their daily living, needing supports to reach their full potential. It's important to note as well that FASD is a spectrum disorder, meaning that all individuals are different and they have their own unique strengths and challenges. So when talking about the prevalence among FASD and Indigenous people, early research did show high rates. However, many of these studies were considered outdated and had significant methodological issues. So one of the first ones was that the studies failed to consider diversity across Indigenous communities, for example, language or geographical area. Second, research was conducted by non-Indigenous researchers that did not consider Indigenous worldviews and perpetuated colonial practices. Third, results have been used to generalize to represent all Indigenous people in Canada, despite being collected from a specific nation that had pre-existing concerns about FASD in their communities. So despite all these issues involving prevalence research, FASD is still recognized as a significant public health issue among Indigenous populations. And this has been echoed by the National Collaboration Center for Aboriginal Health and the Truth and Reconciliation Commission's final report and their 94 calls to action. So the historical context is essential when we're discussing FASD and Indigenous populations, as it highlights the impact of colonial practices on their well-being. The preservation of Indigenous culture, traditions, languages relies on the overall well-being of mothers, encompassing their physical, spiritual, and emotional health. However, practices like the Indian Act residential schools, the 60 Scoop, have disrupted families, communities, and traditional approaches to Indigenous health, leading to a loss of cultural connections and maternal and child rearing practices. So despite the enduring colonization, genocide, intergenerational trauma, and ongoing racism, Indigenous people demonstrate remarkable resilience. One way Indigenous people show such resilience is their ability to maintain their wisdom and culture despite Canada's efforts. When we think about Indigenous ways of knowing in relation to FASD, we can think of three main values: healing-informed, strength-based, and holistic. So healing-informed. For many Indigenous people, healing is based on wellness rather than illness, meaning good health and wellness are more of the absence of the disease. Instead, the aim of healing is to restore balance, harmony in all parts of life considered to be important. For example, connection to the land. The second is strength-based worldview that is inherent in Indigenous culture. So meeting cultural needs is at the center of Indigenous ways of knowings, embracing values like cultural identity, community support, spirituality, and resilience inherently address challenges and healing. The third, holistic. Indigenous cultures embrace holistic approaches to well-being. They recognize the interconnectedness of mental, physical, emotional, spiritual, social aspects of life, as well as their reciprocal relationships with the land, family, community. So diagnosing FASD involves linking alcohol exposure in pregnancy with medical and psychological assessments. And there are multiple diagnostic challenges regarding the diagnosis of FASD among Indigenous people, and I have time to just go over three of them. So the first one is the referral bias, which can contribute to differing diagnoses between Indigenous and non-Indigenous people. This potentially stems from stereotypes, stigmas, discrimination, racism. For example, two individuals with the same symptoms are referred for an assessment. However, the Indigenous individual was referred for FASD, whereas the non-Indigenous individual was referred for ADHD. The second is location. Indigenous communities in remote locations may not have available resources for culturally safe practices. For example, the Yukon utilizes a visiting team of professionals that work with local professionals and provide diagnostic evaluations, whereas in the Northwest Territories and Nunavut, they rely on referrals of patients to clinics in the South. So this kind of forces Indigenous individuals to travel far away from their communities for that medical support. And this can be pretty traumatic considering, the history. The third involves the overrepresentation of Indigenous children in the child welfare system. So this can make it more challenging to obtain an accurate diagnosis of FASD due to difficulties in contacting mothers and gathering reliable histories of prenatal alcohol exposure. So due to the historical and ongoing systemic racism, it is imperative that Indigenous peoples have a cultural safe place in healthcare. Insensitive discussions about prenatal alcohol exposure can be triggering distress and discourage health-seeking behavior. Institutionalized racism shapes Indigenous relationships with mainstream service providers and can cultivate patterns of ill health and impairment. In addition, Indigenous people should not be made to feel like an other or the object of pity or shame. So given the importance of cultural safety, there is a need for clinicians to modify their practices. So how can a clinician make a culturally safe space for Indigenous people with FASD and their families? Well, a study by Hlouet et al. 2023 outlined what clinicians need to know, need to be, and need to do. So what do clinicians need to know? To be culturally safe, there are two key aspects that clinicians need to know. Firstly, clinicians need to have a critical knowledge of the legacies of colonization. This is crucial for developing a genuine connection and understanding the development of vulnerabilities and medical mistrust experienced by Indigenous people. Secondly, clinicians need to consider Indigenous perspectives and culture. This can support positive outcomes for Indigenous individuals with FASD, foster respect for Indigenous culture, and reduce biases. So what do clinicians need to be? Culturally safe clinicians need to undergo an unlearning process to decolonize their practices, their automatic practices that do not consider culture or strengths. This really is an inward journey that involves challenging Western practices. It requires a lot of self-reflection, reevaluation of approaches that stem from Western practices, such as interviews with numerous questions. By unlearning and decolonizing these practices, clinicians can develop a deeper understanding and responsiveness to the cultural needs and strengths of Indigenous peoples. What do clinicians need to do? To be a culturally safe clinician, there are 4 key aspects that clinicians need to do. So first, clinicians need to engage in two-eyed seeing. Two-eyed seeing emphasizes the integration of Indigenous and Western knowledge. This fosters mutual respect, understanding, and learning between Indigenous and non-Indigenous peoples. Second, clinicians need to incorporate family-directed approaches. This approach recognizes the central role of families and allows clinicians to collaborate with families. Third, clinicians need to apply a strength-based well-being approach. This ensures the delivery of culturally responsive and trauma-aware procedures. Clinicians should focus on strengths throughout the process, aiming to cultivate hope, dignity, and respect while reducing stigma. Fourth, clinicians need to engage in advocacy. Research shows that Indigenous peoples often face negative messages and ongoing stigma, which can be internalized. Non-Indigenous individuals need to use their privilege and their power to advocate with Indigenous peoples. This can foster deep trust and help transform lives. And yeah, so that concludes my presentation. And yeah, thank you everybody for listening.
Thank you very much, Jasmine. A wonderful presentation to get us started this afternoon. So our next presenter today is Emma Jewell. Emma is a research assistant with the Psychology, Law, and Neurodevelopmental Policy and Research Group at the University of Guelph, as well as with CanFASD. She is passionate about working and researching in the context of the criminal legal system with an emphasis on mental health and disability. Emma's presentation will discuss developing an FASD toolkit for mental health professionals.
Thank you, Kelly. Just share my screen. Okay, so hello everyone. As Kelly mentioned, my name is Emma Jewell, And today I'm going to be talking about one of the major projects that I have been working on with CanFASD, which is the FASD and Mental Health Practice Resource Guide, which provides FASD-informed information, practices, and resources for service providers, counselors, therapists, and mental health professionals in order to better support people with FASD. So today I'm going to first discuss with you my social location as a researcher. I'm then going to share some information about the purpose, goals, and theoretical framework of the guide, the content that is included, as well as some brief information specifically about FASD and mental health. And then I'm going to end by sharing 3 of the most salient learnings or takeaways I've had from working on this project that are going to inform my work as a researcher moving forward. So here on the slide, you can see some information about my social location. I hold many intersecting identities that impact my understandings, perspectives, and how I see and navigate the world, and therefore the research and work that I produce. It's been an important learning for me as a social worker and as a researcher to continually reflect on my social location and how this positions me in the work that I do. And so I wanted to share that with you before discussing the work that I've been engaging. So as Jasmine was able to provide some great definition on FASD, I'm going to just dive into sharing with you some background information on the FASD and Mental Health Resource Guide that I've been working on. This guide is meant to be an evidence-based resource that has 3 main goals. One is to ultimately support and improve the mental health of people with FASD. We're hoping to do this by assisting service providers and professionals to better support people with FASD through information, practical strategies, and resources. We also want to create an opportunity for mental health professionals to consider their own thoughts, beliefs, attitudes, and practices when supporting people with FASD. It was important to us that our resource was embedded in a strong theoretical framework. And so in collaboration with Dr. Jacqueline Pai, we used the Towards Healthy Outcomes for Individuals with FASD philosophies to guide the development of our project. So the 3 overarching philosophies of the Towards Healthy Outcomes framework that we adopted for this project include 1, taking a lifespan perspective and acknowledging that people change over time. And this includes their capacities and goals, and this can have a large impact on the support that people with FASD need. Considering the interacting systems that can impact people across the lifespan, and consider the importance of mental health support connecting with these different systems in a collaborative approach. And 3 is embedding all of the content of the guide to be strengths-based and empowered. And I'm going to touch a bit more on that a bit later in the presentation. So we've ultimately broken the content of the guide into 8 sections, focusing on various topics that are relevant to mental health support for people with FASD. So the sections include section 1, which is a very brief introduction to FASD, as well as discussing prominent misconceptions of FASD and the impact of stigma for people with FASD. Section 2 goes significantly more in depth about FASD across the lifespan, noting areas of strength and challenge, as well as the impact of FASD on families, caregivers, siblings, etc. Section 3 is a self-reflective section, which invites mental health professionals and workers to engage in activities to better understand and address their own implicit biases and potential areas of stigma surrounding FASD, as well as their comfortability with supporting people with FASD. Resources and links to other information and things are also provided in order to help support that growth. For section 4, this is the specific mental health and FASD section, which also includes a list of promising practices for counselors and therapists when supporting people with FASD. Section 5 goes over the diagnostic and assessment process for FASD, which is important for clinicians to know, as this can be a prominent event in people's lives that they may need support navigating. Section 6 focuses on substance use and FASD, including promising practices for supporting people with FASD and substance use challenges. Section 7 discusses trauma-informed, strength-based, and culturally safe approaches when supporting people with FASD. And finally, Section 8 is best practices and research in the areas of FASD prevention. So because the focus of the guide is on mental health, I just wanted to share briefly some information about FASD and mental health. It's been very well documented since as early as the 1990s that people with FASD experience mental health challenges across the lifespan, which can result in co-occurring diagnoses and other related challenges and difficulties. When compared with the general population, it has been found that people with FASD have much higher rate of mental health challenges, with estimates of up to over 90% of people with FASD experiencing mental health issues. But despite this knowledge, there are very few evidence-informed therapeutic responses and a considerable lack of research regarding approaches to support people with FASD. As such, service providers and professionals may feel very unprepared to appropriately and effectively work with people with FASD, and this may be causing significant barriers in people with FASD being able to seek out mental health support. So actual specific therapeutic approaches for people with FASD is an area of research that is significantly needed to ensure that all individuals have access to effective support. And it may be possible that current approaches such as CBT or motivational interviewing could be adapted and used to the strengths and challenges of clients with FASD, but more research in that area is definitely needed. However, there are common factors across therapeutic modalities that have been highlighted as important considerations when working with people with FASD. We note that it's important to consider each client's unique set of strengths, needs, and challenges, but some of these practices may be important for mental health workers to incorporate into the practice. So for example, building a strong therapeutic alliance. It's been noted that people with FASD have significant relational strengths that can be used to build this strong therapeutic alliance, and that's a very important part of mental health support, as well as things like collaboratively goal setting and creating realistic goals and adjusting language and communication. For additional practices, you'll have to wait to read the guide. So I'm going to just touch briefly on 3 important learnings that I've had while completing this guide. First is the connection of research and practice. So this hasn't been a research project, I think, in the traditional sense of the word or what people necessarily think of when they think of research, but it's an important project nonetheless, because I would say it's an integral component of research, which is connecting research to people's everyday practices. There's been significant research that's pointed to the high levels of mental health challenge in this population, and yet there are still significant barriers to support, such as a lack of knowledge, understanding, lack of FASD-informed supports, and lack of specific therapeutic modalities. So projects like this can help to guide to create a link between the research that has been done to the people who this research can inform their practices, as well as increase awareness of FASD and also point to needed areas for further research. Another important learning for me was about engaging people with lived experience. I've been lucky enough in this project to have a wonderful advisory committee made up of caregivers, people with FASD, mental health professionals, and researchers in the field who have contributed immensely to the vision of this project. The idea of nothing about us without us is extremely important, as engaging the community and the people with lived experience in research is something that has not historically been done. Often communities can be the focus of research, but not actually engaged in the process. But engaging people with lived experience is incredibly important, as they are the experts of their experience on the topic. People with lived experience can provide insight into the real world implications of research. We can gain a better understanding of the needs and concerns of a given population, and it can help to promote social justice and equity. So we wanted to make sure we were highlighting the voices of people with lived experience, both through having our advisory committee, but also through expanding the types of knowledge that we emphasized in the guide. So including quotes from people with lived experiences, videos from that perspective, as well as academic content that was written by people with FASD. And the last learning I've had from this project is the importance of embedding research in a strengths-based perspective. Beyond just acknowledging that people with FASD possess strengths and challenges like everyone, It was important that this was actually embedded in the way that we wrote the content and the structure that we developed for the content. So we wanted to be very careful in the language that we chose and how we emphasized both sides when discussing all of the topics. Often mental health support is very much focused on people's challenges, and while this makes sense to an extent, it does leave out an important ingredient for well-being, which is leveraging people's strengths and abilities. So moving forward as a researcher, I want to make a conscious effort to be strengths-based and include strengths-based questions in all of my research. So thank you all so much for listening to my presentation today, and please stay tuned for the FASD Research Network's guide that should be on their website. And I look forward to answering any questions at the end of the presentation. So thank you.
Thank you very much, Emma. It's always really nice to hear not only about the work, but your own positioning in relation to the work and what you've learned. So I enjoyed that very much. And I'm sure that many folks on the webinar today and in the CanFASD community look forward to the release of that document. So as Emma said, stay posted. Our third presenter today is Pamela Buttinger. Pam is a doctoral student at the University of Saskatchewan and a practicing psychologist in Saskatoon. Pam's presentation today will examine the possibility of an FASD-informed institutional environment for incarcerated and criminal justice-involved adults. So Pam, over to you.
Hello, everyone. Thanks for attending my presentation on effective intervention with incarcerated and criminally justice-involved adults with fetal alcohol spectrum disorder. As Kelly said, my name is Pam Buttinger, and I'm a PhD student at the University of Saskatchewan, which is located on Treaty 6 territory and homeland of the Métis. Today, I'm going to present to you the plan for my research study, which I'm about to start collecting data for this summer. So my research is ultimately sprung out of my professional career working as a psychologist with forensic mental health populations. For the last few years, I've been involved with the FASD Diagnostic Clinic at the Regional Psychiatric Center in Saskatoon. From this work, it quickly became apparent that while diagnosis is like a really good first step, it doesn't always translate into patient care changing because of that diagnosis. It also became apparent that correctional staff in general are interested in having the tools to provide better and more effective intervention if it's available to them. So as such, my current research is looking at how to take the knowledge of best practice FASD intervention and then make that accessible to correctional staff in a way that's useful to their unique circumstances. To start us off, I won't introduce what FASD, given our audience and the fact that it's already been introduced a few times, but I will quickly point out why it's important to consider within the criminal justice system. So prevalence studies suggest that between 8 to 18% of the adult prison population may have FASD, and upwards of 50% of forensic treatment center populations may meet the criteria for a diagnosis if the diagnostic capabilities were available. When considering FASD, corrections was a major focal point of the Truth and Reconciliation calls to action, and I think that's for a good reason. Incarcerated individuals with mental illness in general are already overrepresented and have trouble in many aspects of criminal justice. So when working with individuals who are both incarcerated and have FASD, there are increased challenges around decision-making and reintegration. So for example, parole conditions, treatment for comorbid mental health disorders, the need for structured accommodations, assistance with finances, and the need for connection are all factors that need to be considered. Although Canada is positioned as a leader in FASD research, we know that even here, the diagnosis capacity still remains difficult because of that requirement for the multidisciplinary team and how thorough that assessment process can be. Although this can be a barrier to establishing diagnostic clinics, especially within publicly funded systems, the Regional Psychiatric Center was able to set up and maintain the first adult forensic diagnostic clinic within the Correctional Service of Canada. This clinic was spearheaded by Dr. Mansfield Mila and began in 2018. The original pilot study used patients who were to be released in the next year, but the clinic continues to this day. And within the last couple of years, it's been further supported by leaders within the correctional system and has been branching out to offer support to other treatment centers across Canada to establish their own diagnostic clinics. So for me, it seemed like a good time to start thinking about next steps in staff intervention. According to the literature, barriers to working with individuals with FASD appear to occur in 4 ways. So lack of training, lack of institutional support, limited diagnostic services, and consideration of differential or comorbid diagnoses. It seems that a lack of awareness and recognition of FASD amongst not only general staff, but even clinicians contributes to a lack of diagnoses and development of secondary challenges. Improving recognition is the first step to diagnosis and accessing supports, and only then can we begin to talk about how to bolster the supports available in a particular environment. So when we think about diagnosing in prison, there's a few reasons why we would do that. One, we recognize that there is an overrepresentation of offenders with FASD within CSC. We know that a failure to identify and offer the specialized health needs of the offender population likely contributes to increased recidivism and victimization risk. We diagnose so that we can help staff choose from the right toolkit when intervening and interacting with an individual with FASD. Diagnose so we can challenge common assumptions of the root of behavior and how to respond to it, and so that we can provide recommendations for within the institution, for times of transition, and for care in the communities to draw resources towards the individual. So in this study, I plan to embark on 3 phases of data gathering using both quantitative and qualitative methods. So I want to look at the Correctional Service of Canada institutions across the country, both those with an established diagnostic clinic and without, to determine whether the awareness that the diagnostic clinic's presence brings translates to staff in general being more FASD informed in their interactions. And further, I'd like to determine the baseline of skills staff already bring with them and attitudes that would foster or challenge implementations of new methods of care. Next, I would like to consult experts in the field of FASD research and intervention to help identify quality interventions for a variety of deficits and situations. And lastly, I'd like to gather more in-depth information about what is working and what could be improved through interviewing staff members within those institutions that already have a diagnostic clinic set up. So if a lack of training is actually a significant barrier, as the research would suggest, then it'll be important to discover what types of training would be welcomed and most successfully integrated into practice. The ultimate goal of this research is that the results will lay the groundwork for next steps in developing training opportunities for intervention for FASD that is specific to staff working in correctional environments. So why is it important for staff working in correctional environments to be FASD informed? Surely they will be professional regardless and do their jobs. But first, knowing more about the cause changes how we view those with learning, behavioral, and emotional and legal issues. And then it's a natural human response to make assumptions when we don't know for sure. And that's one of the reasons that skills for identification are important here. So to further emphasize the importance of the correctional staff having an informed approach, I would like you to consider this offender. So take a minute to consider why and how your perspective changed when you saw the age of the individual that we were talking about. Societal norms dictate to us that some behaviors are relatively acceptable when someone is small, but not so cute anymore when the same behaviors are done by an adult. So for example, no one would call an incident of hitting or biting assault when the assailant is a toddler, but the same action is likely to end in criminal charges if the individual is an adult. That's not to say that individuals with FASD should not be made accountable for hurting others, but they often have different developmental age for various cognitive and behavioral domains, but no one can see that from the outside. So if we think back to the expectations that we and the criminal justice system have of adults, we have to ask whether we are applying a fair metric to these individuals. The reality is kids with FASD grow up to be adults with FASD. Everyone here that does research into FASD knows that the evidence supports that adults with FASD face a number of life challenges at higher rates than their counterparts. Education, literacy, legal problems, housing insecurity, and abuse are all common experiences of individuals with FASD. especially those who are involved in the criminal justice system. It's not uncommon for an individual with FASD to have also experienced complex trauma and or several adverse childhood experiences. In fact, there are common symptoms between trauma and FASD, suggesting that being trauma-informed is also a requisite for staff working with this population. So if we think of staff working with incarcerated individuals, perhaps it's helpful to begin to think of certain behaviors through a different lens. This may require some shifts in professional thinking. For example, staff might consider that their role is to help modify the environment rather than changing the person. Further, if we think of behaviors as a symptom of disability or a means of communication rather than malicious, our toolbox to deal with the same becomes different. For example, rather than addressing the situation with more manpower, so for instance, in prison, that may mean calling extra officers for an assumed defiant behavior, the situation may actually call for space to help the individual regulate and understand. As we all know, an important piece of intervention with individuals with FASD is recognizing that a strength-based approach can yield the best outcomes for all involved. While this type of interaction is commonplace in schools and positive parenting, it's often a rather foreign experience for those who are incarcerated. Typically, intervention is aimed at fixing what is bad and not building on what is good. Another challenge that's commonplace within the correctional environment is the complexity of diagnosis and presentation in individuals. So comorbidity with other mental health diagnoses is the norm, and sorting out which diagnosis is responsible for which behaviors can be messy and complicated, and oftentimes challenged by staff. When we consider fostering an FASD-informed environment, organizational change theory can help us understand how staff play a role in implementing and damaging efforts. And it presents a valuable lens with which to view the barriers that have been identified in the literature, especially when a correctional environment is considered. It has been shown that resource limitations, lack of relevant training, and lack of buy-in from frontline workers all serve to undermine attempts to implement change within mental health organizations. Distinctly within a prison environment, the incorporation of rehabilitation programming has always struggled against that backdrop of prison management as one of control that is unfortunately still held by some people in the system. Overall, this research will attempt to uncover the skills that correctional staff already bring to the table, find out what additional training they may need, and feel out whether having a diagnostic clinic on site leads to greater awareness and changed practice when dealing with those with FASD. Further, it will survey effective intervention methods already being used in other environments and consider implementation process questions through the organizational change theory lens. One of the main benefits of adult diagnosis is that it draws resources towards the individual. The diagnostics and recommendations can be used in discharge planning to assist meeting patient needs when released to the community. And while still in prison, a major benefit is the behavior interpretation by staff. Recognition that FASD is a brain-based disability rather than bad behavior increases tolerance, patience, and encourages staff to apply a clinical lens to choose which toolbox they will use to react. That brings us to the end of my presentation. Thank you. And I look forward to answering any questions you may have.
Thank you very much, Pam. Certainly a very interesting project, and definitely look forward to seeing what you find from this. I think there's some really important clinical implications to come from your work. So best of luck with your data collection this summer.
Thanks.
Our next presenter is Lyn Penfold. Lyn is a postdoctoral research fellow working at the University of Alberta on the British Columbia Law Project. Lyn's presentation will explore her interviews with professionals within the criminal justice system, including the use of screening tools and the pros and cons of identifying an FASD diagnosis.
Hello, everybody. Thank you, Kelly, for the introduction. So yes, my name is Lyn Penfold. I'm working at the moment from the University of Alberta, and I'm going to talk to you today about my learning about FASD, which when you first hear about that, it sounds quite selfish, but actually it's from the project that I've been involved in and drawing on my background that I've learned so much about how individuals with FASD travel through the criminal justice system. So my learning is I think, a key component to understanding individuals with FASD. So I'm going to really talk about the experience that the justice-involved professionals who I engaged with, the experiences that they spoke about, and they were referring to individuals with FASD. So it's almost from a secondary and then a third source that I've gained my knowledge. And I think that's really key to my understanding. I don't think it has any effect on the empathy I have for these individuals. Okay, so first of all, I'd just like to acknowledge the partners in this project. It's, as you can see, there's quite a few people involved. I've had really close contacts with people from the University of Alberta and the University of Guelph, and the advisory committee were very key to getting the whole thing going in terms of making contact with justice-related professionals, of whom I spoke to 22. I was really pleased about that. And the 22 participants were grouped into focus groups. So I was able to get perspectives from professionals who worked in the court setting, who worked in the legal setting. So perhaps they were Crown prosecution or defense lawyers. I also spoke to people who have lived experience, who are perhaps caregivers to an individual with FASD. I spoke to community workers, people on the justice front line, many probation officers I spoke to, and there was also a group of medical clinical workers. So if I just come back to the fact that I am at heart an elementary teacher, I hope I'm telling the story that I learned about FASD from engaging with somebody who works as a Crown prosecutor, who would have a very different perspective to somebody who works in the medical and clinical field. So it's really quite a broad range of perspectives that informed my understanding. So back in England, I was a primary teacher for 10 years, and then I taught teachers how to teach maths for another 10 years. And during that second decade, my PhD was involved in asking elementary teachers how they responded to mathematics policy. So it's a completely different world to the role that I'm currently doing. My postdoc work prior to this role was also looking at elementary teachers and their maths understanding. So I hope I'm explaining well enough how new I am to this field. I'm delighted to have fallen into this field. I think it's fascinating and there's lots of work to be done. It is brand new to me, as is the domain of criminal justice, very new to me. So the research itself, the aim of the research is to gain perspectives of stakeholders in the criminal justice system and find out what their thoughts are in terms of how we can improve the supports and structures for individuals with FASD who are traveling through the criminal justice system. We did want to find out about the role of a screening tool and strengths and limitations of using a screening tool, strengths and limitations of identifying individuals with FASD. The current tool that's in use in British Columbia is going to be updated as a result of this research and the other arms that have been undertaken by the other parties on the previous slide. And the impact of the tool is going to be evaluated. And another key component of my part of the project is there's going to be a training program that's designed to help justice-involved professionals screen individuals with FASD and then do something that's going to be positive in terms of their trajectory. So I'm going to just focus on 3 key learnings: knowledge of FASD, individual challenges, and systems and system challenges. So this is what I understand of FASD from my engagement with the participants. The behavior, as Pam just mentioned, the behavior that individuals may demonstrate isn't necessarily malicious, it isn't necessarily willful, and an individual may not necessarily be in uncompliant. It could be that an individual is entering a corrections facility and they're stressed and overwhelmed, and the way that individual responds to the person who is talking to them may come across as being uncompliant, but actually it's nothing of the sort. Something that resonated quite deeply with me was people were saying, well, actually, teachers and school-based staff will recognize atypical behavior and alarms will go off in terms of, well, actually, this isn't the response we'd expect from a child of this age. And yes, that really does resonate, because teachers are fully equipped to know how to respond to children's learning and behavioral needs. They may not necessarily be equipped or actually able to diagnose, but they would know, actually, this child works really well in the afternoons if I put him or her on a table by themselves, because actually their concentration is better. It doesn't need a label to recognize that. And if the behavior is atypical, they may learn, or they may help their child learn, well, this is what we need to do to try and help you manage your behavior. So I think that's a really key point. It's better, this came across very clearly, it's better for everybody involved if youth are identified as having FASD. They're more likely to be in touch with their family, they're more likely to have other agents who have dealt with them at some stage to gather that information to help make the diagnosis. A common misdiagnosis is ADHD or ADD, which won't be helpful as that child progresses through, or that individual progresses through whichever domain they are in. And history of trauma. The participants I spoke to spoke of the history of trauma as almost a recent finding on their part, that they are recognizing now that an individual, yes, they may have FASD and they've had that for many, many years. What's compounding their situation is a trauma that's occurred in their life recently, or in their family's life, either recently or many years ago, and that intergenerational traumatic sense is passed down and is difficult to manage for anybody, and particularly for an individual with FASD. Individual challenges, lack of support became clear, particularly when a youth becomes an adult. And it seemed from the participants I spoke to that they fall out of a system that has, up until that age, been really wrap around and encompassing and supportive. And once that person becomes an adult, that support seems to dissipate, if not fall away altogether. It could be that the screening, or the thought of screening, or the thought of doing any sort of testing or wraparound support occurs only once somebody's committed a crime. It's almost too late at that time if they've committed a crime. The consequences of the justice-related response would be that, or might be that, an individual is incarcerated rather than given a program or asked to do some community-based work to make the rehabilitation a learning process rather than a punishment. It seems that it's more likely that an individual with FASD would be locked up. As that sequence continues, it's also more likely that the individual would not receive bail later, should a crime be committed again, or they lose their bail because they didn't perhaps understand a requirement to attend a session. For some individuals, and this wouldn't be all, but for some of the participants I spoke to, they did mention that there are certain individuals who benefit from being incarcerated. They find that the secure structure is something that calms their situation down, and maybe they can engage with something that they enjoy doing, like playing a sport. The individual that I'm thinking of did go on to stress that it would never be recommended that an individual is incarcerated to give them that support, but the fact that the individual recognizes it can be a challenge. Also, a consequence could be that an individual doesn't understand, maybe they're talking to their probation officer and they don't necessarily understand what their probation officer is saying to them, And then a further challenge is that they may not be able to articulate that they don't understand. So it just compounds the lack of understanding. And I also heard from a judge who said that in court, which is again a stressful environment, that individual may not understand what's being said, but they would put on a really good pretense. And in fact, the word that he used was they would pretend to understand, which is obviously going to lead to challenges down the line. The cycle of negativity. So an individual may be incarcerated a second time, and actually that second time or any penultimate times, or sorry, subsequent times, they just increase the security level of their incarceration, and they don't become good candidates for parole. There's no learning going on there. It's just a challenge. They just seem to be getting clobbered from every angle. More conditions, more opportunity to miss an appointment, more opportunity to breach their conditions. So that cycle is obviously very challenging for the individual. Then I also learned about the professionals' own systems, the systems that they're working in, and how those systems can be challenging. So youth assessments, yes, they can be helpful, and a judge can order for a youth to have a psychiatric and a psychological assessment. But that seems to be less likely, from the people I spoke to, less likely for adults. And there is a cost involved, which could be an indicator as to why it's less likely to happen for adults. The transition from youth to adult, as I mentioned before, is problematic from an individual's perspective, but also the professionals considered it a challenge as well, because they are there to obviously assist and support an individual through the system. And if that individual then falls off of their caseload, what do they do? What do they do? That individual is replaced with somebody else, and they are aware that that individual is now gone. And they feel that, I think the term powerless isn't too strong a term to express how they felt about that transition. Wait time and cost for assessment. So a private assessment costs somebody $5,300, which is an awful lot of money. For youth assessment, I understand that it would take 6 months processing time from start to end, whereas for an adult, that same process could take up to 2 years. And obviously we can think about all the things that can happen within 6 months, obviously, but also what can happen in 2 years for somebody who may have fallen out of the system. And it just seems to be another clobbering. The sharing of records, the professionals did state, yes, the healthcare records must be private, must be kept confidential, but they also almost wished that they could access certain records and just have something on file. You type in the individual's name and you can see, oh, actually they dealt with a probation officer here. Actually, they went to court at this time and this was a conversation that happened. Just anything that can build up an understanding of that individual's record, their experiences, and also how FASD is presenting for that individual. So sharing of records would be really helpful. For community living in BC, if an individual has an IQ of over 70, they are not eligible for community services, which means community living could be a bit of an issue, and particularly if an individual becomes unhoused or is in danger of being unhoused or is released from prison, and all that's happened in the time they were in prison is that they lost their housing. So some challenges that previously I spoke to about from the individual's perspective, challenging for the individual, but from the professionals who are trying to help and get this system going, they are challenged as well. And I really appreciate both sides of that challenge scale. So this was a quote from one of my participants, and I'll just read it word by word. Liz said, The stigma is just huge, and we're written off, and they come back to the 100% preventable message and the blame it's caused by stuff. You know, maybe you guys want to rethink this message because you're not presently preventing it, and you're never going to until a lot in society changes. We're not prevented, we're here. We're here and we are worth something. So Liz is a caregiver to somebody with FASD, and I just thought her quote was so powerful that yes, something needs to be done. It's no point saying, oh, this should have happened. No, these people are here and they are worth something. Absolutely. Very powerful component there. So through the lens of an elementary teacher, at the end of the day, that's where the bulk of my experience is. And I used to have sleepless nights if I was taking my class, or particularly if I was responsible for taking more than one class on a field trip. One of my worst nightmares was that I would come back and I'd lost a child, or something had happened to that child while we were out on a field trip. And safety, keeping individuals safe, if that's part of your professional role, it's got to be paramount in every interaction you take with that person, or every interaction that that person is allowed to access or entitled to access. Safety has got to be key. The support network is also really important, not only support for the professionals and the systems that they're working with, but also support for the individual and their family. Lots of my participants did refer back to family members and how sometimes it's almost a relief when a diagnosis comes through, and the family and friends are then helped to understand, well, how can I support this individual now I know a little bit more about their situation. So support was a key point. Family involvement, particularly while that person is young. Let's keep the family involved. Let's keep the family in an understanding mode so that they can continue with the individual. It's heartbreaking to hear that individuals lose touch with their family almost because the family can't cope anymore. Whereas if those safety and support elements are put into place, it could be that the family involvement can be more secure and certainly can be bound together with interactions from the professionals who understand the situation. Education to me is paramount. So I'm talking about my learning experience. I'm talking about the professionals who have received their job title through an education. And then we're talking about individuals themselves who are at various stages of understanding, regardless as to the level of education they received because of their FASD. And then, of course, as a teacher, I think about the importance of education and how learning is valuable, and learning has to be differentiated for each individual. It almost becomes an issue of, well, does the label count? And several people spoke to that. Does the label count? Does it matter if I'm speaking to somebody who I know has FASD? Or is it enough that I understand this individual has cognitive or understanding difficulties? I understand that, I know that. Let me do something about it. Let me help this person develop. And the assessment component, as a teacher, you assess your children's development in understanding and their behaviour and their maturity levels and so on. That assessment is all judged against benchmarks. It's reviewed with professionals. It's discussed with family members, and the child themselves understands where they are at in terms of their development. So that could lift very nicely into what is needed for not only the individuals traveling through the justice system, but the professionals and the caregivers who are doing their utmost to support them through that process. So assessing where they're at, assessing what they need, getting that need to them, and continuing the cycle. So that's it from me. Thank you very much for listening, and I look forward to asking questions of the other presenters and answering some for myself. Thank you very much.
Thank you so much, Lyn. I have enjoyed the thread today through all of your presentations about your own self-reflection and how your work and experience in the program has changed how you think about things and things you've learned. So That's so lovely. And we're always happy to have new people that come into the field of FASD. So we're glad you're here. Our last presenter of the day is Stephen Lee-Cheong. Stephen is a second-year psychiatry resident at the University of Saskatchewan and has received his medical degree and completed a master's in public health. Stephen's presentation will look at rates of FASD among those involved with correction services. Unfortunately, Stephen wasn't able to be with us live today, but he has pre-recorded his presentation, and we hope that he might be able to join us for the Q&A period following. So Kirsten, I'll let you queue up Stephen's video whenever you're ready.
Hi everybody, I'm Dr. Stephen Lee-Cheong. I'm a second-year psychiatry resident based in Regina with the University of Saskatchewan. Thank you all for coming to today's webinar. I'm sorry I'm not able to join you all live, but hopefully this video will still be informative and interesting for you all to watch. I'd like to share a bit about a project I've been conducting alongside Dr. Mansfield Mela and Ms. Monique Ribaud-Benjamin, which has been about screening certain people with FASD that have come into contact with the criminal justice system and that have been designated a dangerous offender. People with FASD have disproportionately high rates of certain risk factors that put them at increased risk of being in contact with the criminal justice system. Those factors include involvement with the child welfare system, childhood abuse, school disruption, and difficulty maintaining independent living and employment. Amongst the general population in North America, about 2 to 5% will have contact with the criminal justice system, and that's in comparison to the 60% reported for those with FASD, which is quite a huge difference. Even with this overrepresentation, FASD is often undetected in legal settings because of the nature of the illness being somewhat invisible to the untrained eye. A lot of the physical characteristics may not be that obvious, and impairments in mental functioning, even if substantial, may also be somewhat hidden. So unfortunately, this difficulty and resultant failure in detecting FASD, it likely has resulted in poor treatment outcomes, increased risk of reoffending, and overall poorer health for these people. In the criminal justice system, there are people who are designated as dangerous offenders after multiple repeated serious offenses, usually violent or sexual offenses. These people, they pose a tremendous risk to public safety, and management in the community is not really seen as possible, and so often, unfortunately, they must be put in prison for life. Dangerous offenders, they share certain clinical features that often overlap with what is seen in FASD that may contribute to their risk of reoffending and potential dangerousness, including substance use, personality and mental illness, and borderline cognitive functioning. Despite the closeness of the behavioral patterns of repeated offending amongst dangerous offenders and those with FASD, there has been limited research on the link between the two, and so we hypothesize that FASD is prevalent in dangerous offenders, considering this overlap in clinical features. In order for a dangerous offender designation to be made, a compilation of all the information a judge can find about a person, their entire life story, is put into one document that the judge then uses to make a decision on sentencing. Some of these are extremely in-depth, and they really paint a vivid picture of what life has been like for these people, starting from when they're born, going through their childhood, who raised them, any abuse they suffered, how did they do in school, health problems they had, relationships, employment history, and then of course it would include details on the crimes that they have committed. So what we've been doing is applying FASD screening tools to dangerous offender judgments in the provinces of Alberta and Ontario from 2002 to 2022. And from our data, just within Alberta, 8 out of 35, or 22.86%, offenders, they screen positive on the FASD screening and referral form for youth probation officers to be referred to a youth justice FASD program. Then 3 out of 35, or 8.57%, of offenders screen positive on the life history screen to be referred to an FASD diagnostic clinic. And 2 out of those 3 offenders that screen positive on the life history screen, they also screen positive on the FASD screening and referral form for youth probation officers. So overall, there were 9 out of 35, or 25.7%, unique offenders that screened positive on either of the screening tools. The project is still ongoing, and currently we are screening the Ontario cases. 45% of dangerous offenders have 15 or more prior convictions as an adult, and that's really consistent with this repetitive pattern of antisocial behavior that is required for someone to receive a dangerous offender designation. And considering this, we propose that providing appropriate management to FASD offenders early on in their life could possibly help prevent reoffending, and then of course any kind of eventual dangerous offender designation, which would prevent harm to society and of course the offenders themselves. There is something called the National Flagging System, which was announced in 1995, and it was designed to track high-risk, violent offenders who are at risk of becoming dangerous offenders. The system has been shown to be effective, and so we propose that FASD screening tools be applied to those identified through the National Flagging System to help facilitate timely diagnostic clarification and subsequent appropriate management relating to FASD. My experience within this project has not been directly with people with FASD, but rather, as I mentioned, I've been reading the judges' judgment summaries to learn about the different people. Going through these documents, it was often quite sad, shocking at times, especially when they would detail the countless stories of abuse, neglect, and trauma, which superimposed on top of an already damaged brain has made life extremely difficult for these individuals. So when I was able to really understand how life has been for some of these people, I feel that it's easy to see that a lot of them do not really stand much of a chance to have a positive life. I think it's understandable when you read these documents how someone could end up committing such terrible crimes over and over again because their upbringings were just so harsh, and coupled with the fact that, you know, these people have FASD, they have difficulty learning, difficulty controlling their emotions and frustrations, and so I've definitely developed a lot of empathy for them, and I hope that what we propose with this project can help to support them before the point of becoming a dangerous offender. I think that this project could help individuals obtain adequate and timely support, and hopefully change the trajectory of their lives towards something much more positive. Of course, this would also help protect any future victims in society from potential crimes that would be committed onto them as a result of a lack of support for the offenders, usually more so at an earlier stage of their life. Overall, this has been a really eye-opening experience for myself. I hadn't done too much work or research in regards to FASD or forensic psychiatry, and it was very interesting to see how the two fields overlap. I really feel that more support needs to be provided to people with FASD and to vulnerable young children in general who live under tough social circumstances. I think that a lot of the people that end up in contact with the criminal justice system, they are a product of their upbringing, and for many of them, unfortunately, they did not really have much of a chance, like I said, of having a positive life. So I hope this project will be able to help reduce some unnecessary suffering for the people with FASD and society as a whole. So thank you everyone for listening, and I hope by this time I will be around to answer any kind of questions, but if I'm not, then I hope you all enjoy the rest of the webinar.
Thank you very much to Stephen. So I might ask a question to all four of you, following kind of the thread about personal discovery and learning. Maybe what have you learned from one another, or what have you learned from the participation in the program that you've brought into your research or your projects, or even the way you think about FASD?
I think I can go first, Kelly, answering that question. Yeah. So for me, I think one of the biggest learnings that I've had from this program is just how valuable it is to be kind of collaborating and working with others. And just the fact that, like, knowing that my upbringing and my perspectives only really show a certain amount of light on a situation, and you really need to really collaborate and participate with others in order to kind of gain more information and learn more. Because there was multiple times where somebody says something and it's like, oh wow, I didn't even think of that. So I think it's just so essential, like as a researcher, to always be collaborating with other people. So
Yeah, I agree with you, Jasmine. And I think as well, something I've learned from today and from the training is just how broad the field of FASD is. And we all come into it from our own perspectives with our own background. And obviously our experiences are going to underpin how we feel about our research and also how we feel about the individuals with FASD. And what I've learned today is there's so much more to it than numbers and, oh, this person has FASD. There's so much more to it. There's family involved. There's systems involved. And also, if that individual is in the criminal justice system, there are other parties involved who may also have FASD. So it can be a web that's just ever increasing. And I think it's really important that the research, sorry, I'm competing with the motorbike. The research keeps going.
I'd also echo what Jasmine said about the collaboration and the ability to speak with people that have been doing it for a lot longer than we have and get their insights on how they learned and grew all the way through, and hopefully do the same thing.
I think something that's been important for me, and this was actually something Dr. Jackie Pye was able to speak with us about, is determining your why for research. So the impact that it's going to have, or the way that you'd like to use it to inform practices or policy. And I think that's a really important consideration moving forward as a researcher, is really why you're conducting the research that you choose to.
And the so what, Emma? What happens once you finish the research? How do you get that message to the people that need to hear it?
Exactly.
Awesome. So we did get another question that came in that I think actually kind of bridges what you're touching on now nicely. So building on what you have all learned in your work, what would your next FASD related research question be?
I can go first. I've been thinking about this a bit, just in terms of areas that I'm interested in. And because I am interested in the criminal justice side of things, I think one area I'm really interested in is the role of restorative justice practices and programs for people with FASD, and how they could either be adapted or changed to better support folks with FASD through restorative justice practices and programs and things like that.
I think I would be interested in kind of how it looks when people go out into the community and try to reintegrate into community to have a bit of that longevity after they've had a diagnosis within prison, and see if that changes anything for them.
And I would want to ask teachers what their understanding of FASD is. In my 20 years of education, I never heard the term, I'm embarrassed to say. So I'd like to know what teachers understand of FASD and the mechanisms and the support they have in place to help them support that child and his or her family.
I think for myself, it would be interesting to look at how the assessment and diagnosis process can be sometimes traumatic for Indigenous peoples. So looking at how assessment can be modified, how tools can be modified in order to make a more culturally safe place for them. And then also looking into the referral bias and kind of seeing like, why is that we're seeing? So what is influencing that referral bias? Is it maybe misconceptions about what FASD is, highlighting maybe more of the behavioral issues rather than some of the other issues? Or yeah, like could it be systemic racism, and how can we yeah, mitigate those effects as well?
All very wonderful and much needed research questions. And I feel like it's a funny question for a couple of you that are about to embark on your data collection for your current research project and research questions. So maybe goals for the future, and coming out of this program hoping to build you all as future FASD researchers. So maybe questions for later in your own careers.